We'll get started here. So a common presentation to emergency departments, especially amongst pediatric patients, are GI complaints. More often than not, these end up being benign causes such as colic, acute gastroenteritis, constipation. But one of our main jobs as ED physicians is to find the diseases which will not self-resolve and require some sort of surgical intervention. There are a variety of surgical complaints to discuss that present with different signs and symptoms that are related to the GI system and at different ages. And many require different workups, including different imaging, different lab work. Often these children will need to be admitted and require a surgery of some sort. So today I'm actually here with Dr. Francis Idada to discuss this important topic. Of note, we'll be discussing non-traumatic surgical emergencies in children. So no trauma involved, and these are also not neonatal surgeries that we're going to talk about today, like neck or volvulus or those sort of things. So good morning, Dr. Idada.
Good morning, Ryan.
First, can you tell us a little bit about your training?
Yes, thank you, Ryan, for having me. It's a pleasure. My undergrad training was overseas, and I did my general pediatric training in New York, in Brooklyn. And after 3 years, moved to Oklahoma City, where I spent a further 3 years getting a fellowship in pediatric emergency medicine. And the University of Oklahoma is the only level 1 trauma center in Oklahoma City, covering southern parts of Kansas, some parts of New Mexico, and some parts of northern Texas. So it's a big catchment area. And then I've been here for more than 1 year.
Mm-hmm. Well, we're glad you're here. You're fun to work with, so glad you're here.
Thank you.
All right. So thanks for doing this topic with us. So just to start, what are some of the most common surgical emergencies that we'll see in children?
Definitely, as we all know, appendicitis is one of the most common, which we see very regularly, especially in these parts. Second would be, I would say, intussusception. Now, appendicitis is way more common than any other cause, but intussusception is also very commonly encountered. And pyloric stenosis, while not a true surgical emergency, it does require surgical intervention. So we can look at pyloric stenosis as stabilization medically before the surgeons go and do a pyloromyotomy on the kid. So these three, I would say, are the most common, though there are other more serious conditions that are not as common, but we'll get to that.
Mm-hmm. That's good. Yeah. And then also during, preparing for this, I also found that like inguinal hernias are often something that we're going to see as well, I believe.
Yeah, we can also talk of inguinal hernias, and I think inguinal hernias as a whole, either inguinal, which also occurs in adults, but in kids, we also have umbilical hernias, which we encounter, and what I'll call epigastric hernias. The right name is episoelic hernias. I hope I got that right, but hernias that occur between the xiphoid, the middle of the chest, and the umbilicus. The hernias in that location also occur in kids.
Mm-hmm. Interesting. Great. And so if you're working in an emergency department, a pediatric emergency department, or in a community hospital, and you see the triage note, there's some sort of GI complaint. What are kind of the initial things that you consider that go through your mind while you're looking at that?
GI complaints are one of the commonest presentations in the pediatric emergency room. Because the abdominal cavity is almost half of a child's body. So a lot of times kids come in with abdominal pain, diarrhea, vomiting, and all this relates to organs of the GI, either the bowel or other organs therein. So when one encounters that, the first thought is this an emergency? Are there other things in the triage note that tells you that this is not something as serious? For instance, vomiting is a very common presentation in the emergency room, and vomiting with diarrhea automatically makes you think of gastroenteritis, which is not as common, but also could occur in serious conditions like appendicitis and other inflammatory bowel conditions. So basically, I think the first thing you do when you see such a complaint is prepare yourself for anything. It could be surgical, it could be medical. And as I said, when some symptoms occur together, they make you more confident that this is not as serious, like vomiting occurring with diarrhea. But vomiting without diarrhea, it's a little more concerning. Abdominal pain in certain areas of the abdomen, also concerning. So just in the triage notes, you want to prepare for anything. Getting a detailed history is always very important. And when the patient comes into the room, and the detailed history should involve based on the initial complaint. For instance, abdominal pain would be one of the commonest causes of kids coming to the ED, more common than isolated vomiting or isolated diarrhea. And with abdominal pain, the location is the most important because the innervation of the abdomen is the visceral innervation is not very specific, but the somatic innervation is specific. So once the peritoneum gets irritated, the pain is localized to that section of the abdomen. So if you right lower quadrant pain, more likely organs or viscera in that region, right lower, left lower, the same thing, and other areas of the abdomen. So getting a detailed history about location of pain, how long the patient has had the pain for, and then doing a detailed physical exam to exclude things like peritoneal signs. Always a genital exam in such patients might direct you to the etiology of where the abdominal complaint is coming from and further management.
Mm-hmm. Do you think are kids as reliable in their abdominal exams or less reliable than like compared to adults, do you think?
Oh, that's an excellent question. And that's one of the great differentiating great differentiators between adults and kids, because one of the commonest causes of abdominal pain in kids is just functional abdominal pain, which is abdominal pain that has no organic etiology. And many times, teasing out if this is functional or not functional is hard. Also, just like you said, even localizing pain is hard. Kids tend to be more cooperative than adults. Also, a lot of kids might be nonverbal, and in the pediatric ED, you might find parents coming in thinking the child has abdominal pain, like in a nonverbal child, because of things the child is doing, like holding onto the abdomen or bending over. So it's actually the parent's interpretation. The abdominal pain is not the child actually saying he has abdominal pain, but the parent's interpretation. And that is why in the history you have to go into, why do you think your child has abdominal pain? So things like drawing up of the legs, bending over, all these things might indicate to where the child's pain is coming from. But definitely takes more time, takes more patience to actually elucidate what exactly is the cause of the pain and the characteristics of that pain in a child versus an adult.
Right. And then we're often taught, like as residents, when you go into the room, worst first is what you want to rule out. I'd assume it's similar with these patients.
In the adult world, it's easier to rule out the worst first because, as we just said, the history is reliable. The adult can tell you exactly what's going on. But in a child, it's a little bit harder. And sometimes you do not want your history taken to be haphazard. So we normally just use a structured history taken, which would cover so many things in as few questions as possible. And then we can analyze the information we gather. And based on that information, we determine what is going on. So an approach would be just in the history taking, as I said before, what's the duration of this pain? What other comorbidities does this kid have? Has this kid ever presented with such pain? Was the bowel pattern like? Has this kid been constipated before? Because in that history taking, you can easily, just from the parent telling you how this presented, you can easily tease away things that you think are more serious for more common presentations. In an adult, you can go straight to the abdomen and palpate and say, do you have pain here? Do you have pain here? But in a kid, just going to touch the kid will make the parent give you less of a history, and the kid becomes uncooperative, starts crying, so you are able to get all the information you require to make an informed diagnosis.
Right. And then how does age factor into this? Like if you saw the triage note, if you saw a 6-month-old versus a 7-year-old, how do those change your mindset?
Just like in many medical conditions, age is very important. Firstly, because a lot of diseases present within certain age groups and they are less common in other age groups. So in a 6-month-old, though appendicitis occurs, it's not as common as in a school-age child. So once you see the age of the child and also the sex, it points to possible etiologies just based on the incidence of such diseases in such age groups. Now, this does not mean one should not think about such things like in a 3-month-old coming or never think of appendicitis. Of course, it's much harder because this is a non-verbal child. The pain is vague. It's harder to determine where exactly the child's problem is coming from. But there have been a lot of case reports where infants have had appendicitis, and just because of the low incidence in such age group, they have missed it because nobody ever thought of it. But generally, it's more common to have certain diseases and things like Meckel's diverticulum. There's the rule of 2s, which age factor 8-2, pyloric stenosis. These are neonates or infants from 4 to 8 weeks, male predilection. So just seeing the demographics can tell you which is more common than the other. Of course, anything can happen anywhere, but a 5-year-old with Meckel's diverticulum would be very rare. A 3-year-old with pyloric stenosis would also be very rare. So it can, point you in a direction which more often than not is correct.
How about intussusception and appendicitis for their like common ages?
Yeah, so appendicitis, as I said, of course, you can call it within any age group, but more commonly after the age of 2 is when we see kids with appendicitis. School age and teenagers more commonly have appendicitis than younger age groups. Now, nobody knows how appendicitis actually happens. People talk of lymphoid hyperplasia. People talk of, fecally. There are so many theories, but there has to be some transit in the bowel. The bowel has to be developed. Either the lymphoid tissues in the bowel have to be developed to cause obstruction, or the appendix itself has to be big enough to allow fecal contents come in and go out. So appendicitis would be something that are reserved for school age and older children. Classically, we are taught that intussusception is from 3 to 5 years. I'm hoping I'm getting my ages right. That's the classical teaching. I think of it less than 5 years. Intussusception can occur in a 2-year-old. Commonly, it won't occur in infancy. So I use it for intussusception more of the presentation. For verbal, a child who is either pre-verbal or verbal, complaining of certain kinds of pain, who is not school age, would be the kind of child I would think would present with intussusception. But classically, we are taught from 3 to 6 would be the age for intussusception.
Yeah, I mean, that's kind of what they teach us, and I just want to see if that was like actually correlate to clinical practice. Little babies, month or so, pyloric stenosis, then it's kind of the intus stage up until, preschoolish, and then it kind of works into appendicitis. And that's kind of like the way I think about it, but.
That's correct. I totally agree with you.
Cool. Awesome. And so these are all like GI complaints, obviously. There's usually probably going to be some sort of abdominal discomfort, but then there are probably other symptoms that kind of correlate more with certain of these diseases. Can you talk about that briefly?
If we go from the most common to things that we don't commonly encounter, appendicitis, definitely we talked of pain. That would be one of the presenting complaints. It could have associated symptoms, but pain would be something the child would present with. In preverbal children, sign that they have pain might be present, like doubling over, inability to walk, pain on extending the hips. Such things might point to it. For intussusception, classically, it's also pain, but the classical presentation is intermittent pain, where the child has spasms of pain, the child has relief, and the child has spasms of pain again. Whereas appendicitis would not be of a constant pain, and it started and now there's a crescendo. Pain never really went away, was always, the child was always complaining, never was him or herself. Whereas intussusception would be intermittently between the spasms of pain, child appeared to have no problems. And there's also the wiped out appearance that in younger kids, when they present intussusception, the infant or toddler age group, they might have a wiped out appearance where they are obtunded, they are altered, and what they have is intussusception. So part of the workup for an altered kid, who is not responsive, is to check for intussusception, because that has been recorded as one of the presentations. Then for pyloric stenosis, of course, with the vomiting, these are little kids, 2-3 month old, who cannot tell you if they have pain, but they will have persistent vomiting, and always hungry. After vomiting, they want to refeed. And that would point you to this might be pyloric stenosis. And as I said, that really is not a surgical emergency, but it's something to catch early so the children don't have complications of hypochloremic acidosis, hypokalemic acidosis. Then less common things like Hirschsprungs would be no bowel movement for a long time, hernia, there'll be a bulge, there could be pain for a carcerated hernia or strangulated hernias. For things like Meckel's, there'll be bloody stool. Without painless bloody stools will point you to this could be Meckel's. And these are things that don't happen commonly. Some very serious things that nobody should miss is volvulus, and classically that would be bilious emesis. And I think that's why all of us say for every emesis it was non-bilious, because once there's bilious emesis, technically we have to rule out volvulus, malmutation with volvulus before we go any further. So that would be classical thing for volvulus. Other types of obstruction from adhesions might present with vomiting early or constipation early, depending on if it's a proximal obstruction or distal obstruction. So proximal obstructions will present with more of early vomiting, less of distension, while distal obstruction, like colonic obstructions, things like Hirschsprungs will present with earlier with distension, later on with vomiting, and all these things will have constipation associated with them. Also, you could have masses, which are surgical emergencies, so to speak, any surgical intervention in the abdomen, which just present with abdominal distension without significant pain, vomiting, or diarrhea. And physical examination would show, this child has a distension. When you palpate, you could feel a mass in the belly, and further workup will be done. So this would point to different things that we encounter for GI emergencies in the ED.
Yeah, and I mean, all those descriptions, those are like, that's what we're taught in med school. Those seem like the classic presentations. Do you often find that, they don't always present like that, and we just have to be a little bit more liberal and suspicious?
Oh, definitely. Appendicitis would be the most common because it could present with just diarrhea, not much of pain. It could present with just vomiting, and people have tried to create scoring systems to determine if there's appendicitis or not. But more often than not, we are more liberal with imaging and workup, so we don't miss cases like that. Also, obstruction could also just present with a little bit of vomiting. It could still, constipation might not be a noticeable, or parents have not really noticed it and would not report it. So definitely investigations would help. And abdominal emergencies are one of the things which we investigate commonly. I think second to pulmonary causes, like a child coming in with a cough and doing an x-ray, because it's so difficult clinically for you to determine if this is, just appendicitis versus just functional abdominal pain or mesenteric adenitis. So more often than not, we end up getting imaging, getting lab work on such presentations to tell us what is occurring. Definitely things like Meckel's would have classic presentations. So the workup for such conditions, one, it's expensive, it's very intensive. So we tend not to, if they do not present classically with, bloody painless stool, we tend not to work up for that. So some things that don't occur commonly, we tend to rely on the classic presentations. But things that occur commonly, like intussusception and appendicitis, we are more likely, if we are not sure, to get imaging or blood work to tell us if the child has this or not. Right.
And then, so speaking of lab work, what kind of labs are part of that belly panel, or what do you commonly order?
I think for now, the practice is just routine labs, the CBC. White count is always something in many conditions that helps. If it's elevated, we're thinking of an infectious source. So that would be differentiate between the two top common causes of abdominal pain in kids: intussusception, appendicitis. Intussusception, as we know, is not infectious versus appendicitis, which is infectious. So fever, elevated white count would point more to appendicitis than intussusception. Of course, anemia from blood loss, if there's no report of blood loss, either from ischemic bowel, losing blood in the stool, or Meckel's diverticulum. The hemoglobin is always very helpful. The platelets also helpful when you do a CBC, because some causes of abdominal pain, which I've not mentioned, these are not really surgical emergencies. they're medical emergencies, but they present with abdominal pain and they might confuse you with appendicitis. A child who has sculling purpura could have hyperplasia in the abdomen and present with severe abdominal pain. Some even go ahead to have intussusception. So if you do a CBC and you see low platelets, that will point you to it versus running down the rat hole of appendicitis. We always do a chemistry because in many of these conditions, children are not eating, children are vomiting, they have diarrhea, they could have electrolyte abnormality, which would determine their surgical disposition or your resuscitation efforts to address any abnormality. Also, some conditions, as I said, like sculling purpura, which could present abdominal pain. You could have AKI, or even in a common condition like appendicitis, where the child has not eaten, either ruptured appendicitis with abscess, severe dehydration, and the child is an AKI. So you want to always make sure that the creatinine is good, the BUN is good, because sometimes you need to image these kids and you want to have a baseline of those things before you go ahead. Then I commonly do a CRP. And why I do that is because you want to have a baseline also. Though the ultrasound might say it's perforated or not perforated, if the CRP is negligible and after management CRP is elevated, that may be a point to an abscess forming after intervention. So I commonly add on a CRP. These are very cheap tests and they are run in a panel. I also add an ESR, and why I do so is that uncommonly you could have autoimmune conditions, IBD, which presents with abdominal pain, right lower quadrant, and you could confuse them for appendicitis. So in a situation where all the labs are normal, but you see an elevated ESR, you might start thinking that this might not just be classic appendicitis, this might be IBD, this might be Crohn's, this might be some other kind of inflammatory condition. So basically those 4 labs I get, we tend to add on a lipase. Though pancreatitis is not as common, but it's, as I said, it's an easy test to do. You're doing drawing blood, so we just do it once. Elevated lipase would point you to pancreatitis as the cause of non-specific abdominal pain, especially epigastric abdominal pain, and help you to, which will guide your management. All that and depends on the presentation. For volvulus or severe presentations, you could add on a lactate, either a VBG lactate or standalone lactate, because the bowel, once there's ischemia and the bowel is dying, you could find elevated lactate, and that would guide the urgency of intervention. So elevated lactate, which you have resuscitated with fluids and it's not coming down, you want to get the surgeon quickly in, because once bowel dies, there's really no, unlike heart transplant or kidney transplant, there's no bowel transplant. They have to take that bowel out, and now the child has short gut syndrome for the rest of his life with the attendant complications. So I think routinely, I think of those 5 labs I mentioned: the CBC, CMP, CRP, and ESR, the lipase, and depending on the severity of presentation, I also occasionally add on a lactate.
Mm-hmm. It seems like the labs aren't as helpful in diagnosis, more in like prognostication about how sick are these kids actually. It seems like for GI.
And it depends, yes. And it depends on where you're working. So in some places where you don't have access to an ultrasound to diagnose appendicitis, labs are more helpful there, because a lot of the scoring systems include lab values. So leukocytosis, ANC greater than 10,000 is used in the etiology of appendicitis. So if the kid presents with right quadrant pain, fever, high white count, this could point you more to appendicitis versus other causes of abdominal pain. And you could actually call the surgeon with the labs instead of doing a CT, and the surgeon could decide, based on the white count, based on the presentation, I'm going to take the child to the operating room and save the child getting irradiated.
Mm-hmm. That's good. How about a urinalysis?
Oh, yes, I forgot that. Yes, yeah. That's something I commonly do for all abdominal pains, especially in females. I also add in a urine HCG for females, because the abdomen is continuous with the pelvis, and a lot of pelvic pathologies actually present with abdominal pain. So pregnant females can have abdominal pain, and they present, which would be an OB emergency. Also, just appendicitis and that's why we talk about appendicitis so much, because the base of the appendix is fixed, but the tip is mobile, so it could be anywhere. When the tip is irritating the bladder, a child can actually present with pylorus and signs of a UTI. But this is not a UTI, this appendicitis, just because the appendix is inflamed and irritating the bladder, and that's why you find those changes. So I think commonly we're taught that if you find pylorus and there's no bacteria, there are no nitrites, you should not be not be confident that it's a UTI. It might just be appendicitis as the cause of the abdominal pain.
Mm-hmm. That's a good point. Excellent. But then imaging is kind of like the foundation, it sounds like, of this.
Yes.
So
Yes.
what kind of imaging do we talk about?
So for all, as I said, depending on your etiology based on your history and physical, and that will guide what imaging you would do. The modalities we have commonly are ultrasound, ultrasound and CT scan. Occasionally, X-rays are very helpful to find things like obstruction. They are helpful and they are the fastest available imaging modalities. So we are thinking of conditions that would present with obstruction, abdominal distension, like post-surgical obstruction or hernias with abdominal distension. X-rays will help, and they will show dilated loops of bowel. They would show no air in the rectum, and this would direct you to, this is an obstruction that needs surgical intervention. For intussusception, this gold standard is an ultrasound. The ultrasound would show the donut sign. The CT scan can also show it, but ultrasound is safer to do, and it's even in moderately experienced hands, they can find intussusception versus appendicitis, where you need experienced operators to actually visualize the appendix and do the measurements. And I think the measurements we commonly talk about for ultrasound are 6 millimeters diameter of the appendix. You could also look at the wall of the appendix and look if there's fluid around the wall of the appendix, measure the size of the wall of the appendix, and look for fecalith or radio materials in the appendix. Then of course, if you don't have access to experienced sonographers, you have to rely on CT scan for the appendix. And the same signs you see a dilated appendix, you might see fecalith with radio-opaque materials in the appendix, and that will tell you have appendicitis. And unfortunately, these days, most surgeons want radiographic evidence of appendicitis before they take out the appendix. But appendix could be a clinical diagnosis based on the presentation, and surgeons could actually go and take it out. And studies have been done to show that clinical versus radiographic, the outcome is equal when they did pathology of the appendices that were taken out. So all CT scan, ultrasound would be the common ones we use. X-rays also very common. Uncommon things would be a nuclear scan for Meckel's diverticulum to see if there's uptake in the diverticulum itself. But that you have to have strong suspicion based on history and physical for your other such nuclear scan.
And then a couple questions. Pyloric stenosis, what's the imaging for that?
Pyloric stenosis, it's ultrasound. But why I don't like grouping that, because I said it's more of a medical emergency than surgical. But it's ultrasound, and they measure the pylorus and their dimensions they use to determine. I don't have them offhand, but the wall that they use the pylorus to determine if there's stenosis or not. And they also look at transit of they feed the child and look at how food goes through the pylorus, and that is the definitive diagnosis of pyloric stenosis. Right. No X-rays, no CT scans.
Right. And then with intussusception, ultrasound's great. If the sonographer does an ultrasound, it can't see it, but like clinically, it just seems like it's an intus. Will they go ahead and do an air enema, both for diagnostic without confirmation of being an intus, or do you usually just use ultrasound, or what do you think?
Yes, in all the places I've been to, without the radiographic diagnosis of intussusception, I don't think the radiologist will actually go ahead and do an air enema for several reasons. One, an air enema, you're introducing foreign contrast into the bowel or air into the bowel, and abdominal pain, as I said, it's a very vague presentation, and intussusception and appendicitis could present the same way with other less common causes of abdominal pain. So you have to be sure that there's no perforation before you introduce anything into the bowel, because if you just introduce it for diagnostic purposes, you can cause very fatal peritonitis, and that child could lose a lot of bowel. So in most places, they want to establish that this is intussusception before they go ahead and do it. And before ultrasound was actually commonly used to diagnose intussusception, radiographers or radiologists use x-rays. So with x-rays, if there's no air in the right lower quadrant, signs like the Sitama sign, sickle sign, they used to see if the small bowel was actually transiting through the cecum into the ascending colon, through the transverse colon. Of course, with that, you can only diagnose very late intussusceptions, but early intussusception is easier to use on ultrasound. So I think if you do an ultrasound and you cannot definitely say this is intussusception, one management protocol would be to keep the child, do serial ultrasounds and see does the pain resolve or can you diagnose intussusception. But I'll be hard pressed to find a radiologist or a surgeon who would agree to go and do an enema without a radiographic diagnosis of intussusception.
Where's the role of CT, I guess? That's what's hard for me to wrap my head around is, you get an ultrasound, you really think it's intus or you really think it's an appy, and it kind of comes back equivocal. Is that when you go ahead and do a CT, or what do you think?
Yeah, so it depends on that's a very good question, but I think that question, I think the answer, that's the art of medicine, because there's no textbook that will tell you this is the protocol to use. And I think in making your decision as an ED practitioner, the things you put in mind are what was the severity of this child's condition? How long has this child had this condition? What is the possible follow-up for this child? So you already have several etiologies in mind, and your CT scan is trying to differentiate one from the other. And when we also keep in mind that functional abdominal pain is also one of the causes of presentation to the ED, just going ahead to CT these kids, exposing them to radiation, which was a common practice in the past, is not as advisable. So a lot of centers, serial abdominal exam becoming more and more common. So in the ED, depends how comfortable based on the presentation of the child. Is this a child you feel comfortable with sending home based on social factors, severity, duration, and the child's age? Or is this a child you want to keep in the hospital and repeat an ultrasound, which is less radiation, less harm to the child? Or is this someone you want to just go ahead and do a CT scan? Of course, for many conditions, CT scan, we definitely rule out some things and rule in the others. But when you think of the radiation you're exposing the child to, in some cases, it might not be worth it, especially early in the disease, when even if there is some sort of inflammation or problem, even CT scan might not be sensitive in ruling it out, which, you did a CT scan after 3 hours of abdominal pain, CT scan says the normal appendix. Can I confidently send this child home if the child still has abdominal pain and it's not resolved with my medication, or do I want to keep the child? So nobody will CT a child 4 hours after one CT, but everybody will be confident to do an ultrasound 4 hours later, which is the standard. You can do an ultrasound now, if it's negative for intussusception, you can repeat it after 4 hours and see if you see anything different. So I think we should be more, now when the scale of ultrasound is, more widely available, a lot of people are more conservative with how often they scan kids. But as I said, you have to think of, so a teenager who is 17 or 16, you might be, more liberal with doing a CT scan versus a 3-year-old who is still growing and his organs are more susceptible to tumors and, other malignancies.
Yeah, I know, like for an adult, they're 65, they have some abdominal pain. I'm getting a CT scan often to kind of rule stuff out. It's like, I think they're fine. Let me just get a CT to make sure. Where with the young kids, I almost feel like the CT scans are to rule in. You're like trying to convince the surgeon or somebody like, hey, something's really wrong here. So with that, if you're trying to rule stuff out though in kids and not rule it in, like you were saying, give it some time, repeat exams, repeat ultrasound seems just much safer and reasonable. Let time be the diagnostician,
Yes, that's completely correct.
Yeah, if a scenario for you, say I'm a community doc, and I'm 2 hours from like a pediatric center, and I have a kid who I'm kind of unsure. I'm not terribly convinced this is an appy, but I can't really rule it out. our tech tries to do an ultrasound and it's negative or equivocal, is it reasonable to transfer somebody to a children's center just for another ultrasound or for repeat exams?
Okay. Yeah, that's a great question. And as I said, it has to do with what the presentation was. When I was training in residency, we didn't have a competent radiologist and sonographers. So we did mostly CT scans. So then your clinical acumen now becomes more important for you to look at the whole picture, severity of the pain, location of pain, presence of fever, duration of symptoms, additional symptoms like vomiting or diarrhea. Can you explain the presentation by something else, better than appendicitis? And in some cases, it might be reasonable for you to scan the child. And as you said, depending on how far the child is from a center where intervention can be done. The intervention is a center that has a pediatric surgeon. So if you are not close to the place where a pediatric surgeon is present, transferring the child to that center is completely useless. So you might, in that case, decide to do a CT scan right where you are versus transferring him. But if this is a child where you're unsure, based on your exam, based on the history, as you said, you tried an ultrasound and you couldn't get it, and the child symptoms are not very severe, and the child can be safely transported, then it might make sense to transport that kid. So it's just on a case-by-case basis. Some kids are not stable enough to be transported 2 hours just to say, do they have an appy or not? Because I don't want to radiate the kid. But if a kid is with severe abdominal pain, the labs are all abnormal, vital signs unstable, of course, nobody's going to fault you for going ahead, because appendicitis is only one of the causes of abdominal pain. Right. If the child has a bleed, if the child has a tumor, that so many other things can cause it, and many of these things, only complete visualization of the abdomen will tell you what's going on. So a lot of people would support doing a CT scan to actually find out what's going on in this unstable child who is in severe pain, versus transferring an unstable child who now might arrest while he's being transferred to this pediatric center because one is not comfortable with kids. So I think in that situation, doing a CT scan is really warranted.
Mm-hmm. Yeah. Yeah, it's the sick kids, I feel like it's not as hard to make the decision. When they look sick, go ahead and do it. It's like those not so sick ones, but you're just kind of unsure. So you did kind of mention all the symptoms of appendicitis. I know there's scoring systems for that, right? Do you ever use those, or?
Oh yeah, so initially I used, but when I came to El Paso, I found out that I don't know where they did the studies, the pediatric appendicitis score, which was based off Alvarado's score, was validated in different big centers. But I find in our population here in El Paso, definitely these people didn't read the textbook, because if they did the study here, I'm sure this would be not valid in this environment. So initially I used the pediatric appendicitis score, which gives 2 points each to migration of abdominal pain, heel tap tenderness, and pain in the right lower quadrant, and gives 1 point to presence of fever, anorexia, vomiting. Also adds on lab features like the ANC and co. So in our environment, first of all, I don't do labs before I do an ultrasound. So the scores are less useful because they all have lab components to them. And these are scores that are useful where you don't have, these were done where ultrasound was not as prevalent. So they expected, when you suspect appendicitis, to get blood work and use the results of blood work in addition to the clinical presentation to say if this child, the likelihood of having appendicitis. And based on that likelihood, if it's, more than 8, for the pediatric appendicitis score will be the most common. I think they are ones that are not as widely used. So more than 8, highly suspicious, you can go ahead and call the surgeon. Between, I would say 6, 7, you can do imaging too. Then less than 3, I think, less than 1, 2, 3, very unlikely. 4, 5, 6, moderately likely. 7, 8, 9, 10, very likely. So, but I don't use them often. I just go by clinical guest child, because a lot of kids in the environment come with only abdominal pain and they have appendicitis. Some come with vomiting, anorexia, right lower quadrant pain, fever, and they have nothing going on. So it's very hard. The sensitivity in the environment is very low. and specificity is also low. So I go by the clinical gestalt. Unfortunately, more kids will get ultrasound, which really is safe. It's just the cost factor and the time factor, because they have to wait in the ED to get an ultrasound. But with the presence of ultrasound now, I think those scoring systems are not as useful. But as you said, if you're in a place where you don't have access to ultrasound, then the scoring system might be more useful, because you want to get blood work and you want to use the clinical signs to determine if this child had appendicitis or not. As I said, pediatric appendicitis score is the most widely used.
Mm-hmm. Are there any others that are reliable, like for intus or any of the other ones, or mostly just the appy, right?
Yeah, just appendicitis has, I think, as far as I'm aware, just appendicitis, and all others just the clinical presentation.
Right. All right. So we have a kiddo comes in, we get the imaging, we confirm whatever diagnosis it is, some sort of surgical thing, appy, intus, whatever. What do you kind of do from there?
So it depends on the etiology, because most of them have different presentations. Of course, getting IV access, resuscitation is one of the prime things we do in the ED. You want to make sure this child's vitals are stable. You want to address pain, which in my books is still a vital sign. So when these are addressed, then you can call the surgeon who would do the definite intervention. Because some kids who present will be hypotensive, you have to resuscitate them with fluids effectively. And as I said, in a thing like pyloric stenosis, they may have hypokalemia, they may be hypochloremic. You want to give them fluids, you want to recheck labs, you want to make sure you have corrected that electrolyte abnormality. In intussusception, you want to make sure there's no bowel perforation. You want to get a lactate, make sure the lactate is normal even before you go and try your enema, because if there's perforation and that enema is down, they're going to cause a peritonitis. And that's why in most cases of intussusception, even before they attempt the enema or the contrast enema, whichever is going to be done, the surgeons have to be on standby, because if there's perforation, that child has to go immediately to the operating room. So from our standpoint, we want to make sure this child's condition is optimal for whatever intervention is going to be done, based on the electrolyte, based on the fluid status. If this child is febrile, you want to address the fever. If this child is in pain, you want to, I'm very liberal if I think it's a surgical mediated pain like appendicitis, like intussusception. I'm very liberal with opioids in the ED, so you want to address that pain before the child is taken to the operating room.
I was actually
asked that. I forgot, MPO is also an important thing, because most parents, unlike adults, want to feed their kids once the kid is not screaming in pain. So you want to remind everybody that, this child possibly will be going to the OR. So please, most medications can be given IV. Even Tylenol for pain, you can get Omifev and give the child. So nothing by mouth.
Right. I was actually going to ask about that for opiates. You're okay with even little ones, 6 months, a year, if they look uncomfortable, you give them that, or kind of where's the cutoff?
Yeah, so as I said, this is for surgical pain. Now, most 6 months old, unless they have a visible hernia, which you are going to try reducing, and all literature supports opiates for reduction of hernias before you try to reduce it. So definitely after 3 months, I'm very liberal with the opiates. If I'm going to do a procedure for neonates who have, hernias, I wouldn't even attempt reducing that in the emergency room. I would rather take the child to the NICU and have the pediatric surgeons do that. But in all age groups, opiates are very safe. Of course, you have to do weight-based dosing. Even neonates, you can give fentanyl safely. You just have to be aware of the side effects that can happen in that age group. So younger, like a month, 2 months, they can have a wooden chest if you give fentanyl. So you have to have naloxone on standby, that if they do stop breathing, they become apneic after you have given fentanyl for pain, you have your Narcan ready to immediately give them, so you do not have an arrest on your hand.
Yeah, that's real good. Since you mentioned hernia, just having a hernia is not a surgical emergency, correct? It's only if it's, strangulated. How about if it's, which, we'll get labs and we'll prognosticate with that. How about if it's incarcerated? How about if you can't reduce it, but they don't seem like they're an extremis? Is that something you would admit and get taken care of right away, or can that follow up closely?
So generally for an incarcerated hernia, those are not kids that typically will be sent home, even literature, just because that is a continuum from reducible hernia, irreducible hernia, incarcerated hernia, strangulated hernia. So the hernia is really not going to tell you when it's going to strangulate. It just keeps on progressing. So we do everything, and I mean, in the textbooks, all have the procedures for reducing hernias with opioids, positioning, pressure to reduce it. And if we can't reduce it in the ED with all these interventions, sometimes you have to get the surgeons on board. The child might need more, more than just pain medication. The child might actually need, depending on the age of the child, needs sedation to get that muscle relaxation to reduce it. So incarceration is an emergency. If you cannot reduce that hernia with all attempts, you have to involve someone with specialized skills that can either, sedate this child and try to reduce it or surgically reduce it, just because an incarcerated hernia can become strangulated at any time, and you would not know when it will strangulate. So sometimes we say, and some hernias, even though you actually reduce them successfully, they appear again after successful reduction. And in those cases, if they do reappear, but you can successfully re-reduce it, then you can, so those are like reducible hernias. Kids can go home with their parents, and you have to establish that there is very quick follow-up with the surgeon to correct it, just because of the risk of strangulation and bowel loss. As I said, incarcerated hernias, definitely, that is my, and as I said, medicine is an art. My practices for incarcerated hernias, I get the surgeon involved. And because it's an art, there are also things you think of. I mean, a very small incarcerated inguinal hernia, a very small, which you can't completely reduce. I may be not as concerned about that as a very big bulge in the scrotum, which won't go back, which the scrotum is bulging, the child is crying in pain, and we have done everything for pain, but this child is still, crying in pain. So for those ones, I definitely would involve the surgeon, because they might soon become, the venous blood flow might stop, and therefore arterial, and they become ischemic.
Excellent. I feel like we've talked about a lot of good stuff. I do have one other question about pyloric stenosis. I don't think we covered it as in detail. So you're saying that it wasn't as much like a surgical emergency. A kid that you think has a pyloric stenosis but is PO tolerant, can they be sent home?
So generally, so not just PO tolerant, you have to establish that the child has no electrolyte abnormality.
Right.
So pyloric stenosis, they might be PO tolerant, but they would throw up later on because there's hypertrophy of the pylorus. So just vomiting, it's not the, should I say, that's not the only diagnosis that, because this child vomited, the child has pyloric stenosis. Now, the ultrasound is done, it documents hypertrophy of the muscle, the child drank, he didn't throw up once. The food might be still in the gastric cavity, but it's when it's trying to transit, the child is going to vomit. So unless you want to keep that child in the emergency room for 24 to 48 hours to actually document, this child has been here for 2 days, the child has eaten and not vomited, and then I think I can send home. But generally, once there is documentation of hypertrophy of the pylorus, the next thing to do, and the ways described, people are not born with pyloric stenosis, and that's why it's idiopathic hypertrophic pyloric stenosis. It actually starts developing after birth. And so symptoms initially are very mild, occasional vomiting, but then as the pylorus hypertrophies, by that 4 to 8 week, it now becomes so thick that milk liquid contents are not passing, and most of the time after eating, the child vomits. Of course, here we never see the olive, whatever they talk about, because we catch it early, but these things were described in a time where there was no ultrasound. So kids actually presented as medical emergencies. So they presented with very low calcium because they have been vomiting and vomiting, low potassium also because of the vomiting. So in a situation where the child comes in and you suspect IHPS, you do the ultrasound, you document it, and you do the labs, and there's no laboratory abnormality. This is early. Of course, it's not a surgical call, legally. Do they want this child to go home and come back the next day for an elective procedure, or do they want to keep the child in the hospital and do the elective procedure the next day? Now, this is just up to the surgeons about concerning their practice. But remember, this, as I said, this is a chronic thing. It didn't happen the day before. It didn't happen 2 days before. It didn't happen 1 week before. It's taking weeks to occur. So this child going home doesn't mean, as much as the child has no electrolyte abnormality, the child is not going to decompensate within 1 day. The process is just going to continue until the child has the metabolic derangements that accompany pyloric stenosis. So that's why earlier than not, the surgeons rather relieve that obstruction, because it's a very simple procedure than leave the child to become metabolically deranged and have complications thereof.
Yeah, I mean, that actually, I didn't understand that clearly, so I'm glad you clarified that, because it makes sense. Appendicitis comes on quick, intussusception comes on quick, a hernia that gets stuck comes on quick, stenosis not so much, that took time, so that actually makes a lot of sense.
Yes, yes. Yeah, because parents are home for several weeks, their kids are vomiting, and they have gone to several doctors, and then finally someone says, let's check for pyloric stenosis. Oh, he has pyloric stenosis.
Mm-hmm.
So, but it's not something that we think 24 hours to 48 hours if there are no metabolic derangement. So now if you catch the kid and you do the labs and potassium is 2, you're not going to send that child home because the child is going to come in and rest because of pyloric stenosis. So you want to address that metabolic. So that's why kind of people look at it as this might not be a surgical emergency, more as a medical emergency, but definitely the surgeons have to be involved.
Mm-hmm. Great. Awesome. So we've talked about a lot of the presentations. We've talked about labs, imaging. So working with residents, what are some common pitfalls that you've seen with residents working with these types of patients?
I think that the commonest is that it depends on the background, So I think the commonest pitfall for anybody, resident or doctor, would be historical and your physical exam. So if you don't take a detailed history, if you don't do a focused physical exam, you're going to miss signs that will tell you what's going on. The history is the most important about, onset, duration, what else is going on? Is this kid on medications? Is this kid growing appropriately for age? And that might save you doing unnecessary investigations or just taking you off course. So I think history will be the most important. Then physical exam, a lot of residents, of course, they know the psoas sign and all these signs that you can do. But just laying your hands on the kid's belly and just, trying to patiently find out, because unlike an adult that you can quickly, within seconds to a minute, find out, where is the pain? Where is the pathology going on? In a kid, you have to be more patient. When the child is anxious that you are coming, the child's abdomen might be rigid just from him being crying or being anxious. You may have to wait a little bit for in between when the child is crying, see if when you palpate, is the abdomen soft or not. Now, is the child crying because the abdomen is tender, or the child is crying because the child is anxious? So using other things to calm the child down while you child to perform your exam is also very crucial. Of course, looking at as I said, the genitals is something you must look at in every person who comes, in males especially. Females, not as much, but in male, you must. In females, I always say, of course, because of modesty, you can look at the groin, because females could also have hernias. And in a female with a groin mass, legally, you have to make sure the ovary is not in that mass. So every female with a groin mass has to have an ultrasound. Mostly we ultrasound most hernias just to see if this is just a hydrocele or if there's bowel content, but especially for females. And if you're in a center where you cannot do that ultrasound, you should transfer that. Most of them will present stable. You should transfer them to a pediatric center where they have an ultrasound that can document that there are no ovaries in this hernia. Because if there's an ovary in that hernia and the ovary torses and dies, you'll be liable for that girl's reproductive health. So basically just being very patient in the exam, calming the child down, trying to get a good exam, being patient in getting a history from whoever the caregiver is about the duration, the onset, the character of this pain, where did the child first complain, where is the child complaining now, is it all the time the child is complaining, any associated factors that make this pain better, any factors that make the pain worse. Because though we are focused on surgical emergencies now, renal colics could present exactly the same like an appendicitis. And if you don't take a good history, you might, go do an ultrasound, then do this, then do that. But if you take a good history and a good exam, it just points you, okay, this is exactly where I need to go. And more often than not, when you do the imaging necessary to diagnose that, you see what is going on.
Yeah, I was actually thinking, we work with adults mostly. And so, I feel pretty confident with, appendicitis, diverticulitis, gallbladders, things like that, adult diseases. But kids have a differential diagnosis, which is why I wanted to talk about this today. If you don't come in thinking there's a hernia down there, or if you don't come in thinking about one of these diseases like an intus that we don't see in adults often, you're not going to take a good history. So like the differential is really important to know for these kids. That's why I like talking about like the age considerations and just like what we see at this time. So this has been really, really beneficial for me. I really appreciate it.
Thank you.
Do you have any like final things you want to add or?
Yeah, as I said, I can't just reiterate it enough. I know from the adult standpoint, it's mainly, let me think of this diagnosis, ask questions to eliminate this, then ask questions to eliminate that, then ask questions to eliminate the third one. Most of the time, because kids are uncooperative, you're asking not the patient, you're asking the parents. Just having a format that, for every, not even for every abdominal pain, for every complaint that ever comes in, this is just my format for. I'm going to just find out, when did this start? What's been going on? Just tell me in your own words, what's been going on? Then look at the child itself. Like, is it crying? Is it calm? Is it, fretting? There's a gold mine of information in that. It's very different from adults. It's not just the etiology, which is important to know. This occurs in kids and it doesn't occur in adults, but also your approach to get the information might save the child unnecessary investigation, save you time, and make you more comfortable, because the more the ED resident hears these stories, the more intuitively just hearing the parent say one or two things, oh, I am very sure that from what the parent said, this is what's going on. So, but when the parent is just asks very close-end questions, the parent won't give you the necessary information. You might just, oh, do you have pain here? And the child says yes, no. They might not give you, the correct information. So I'll just go back to not just ED, every doctor, just taking a detailed history, being a little more patient. Luckily, as I tell the residents who work with me, adults have a high volume in the ED. So throughput is the most important thing in the adult ED, getting them, getting a safe disposition for them. In many places, I would say most places I've worked, you cannot compare the volume in the peds emergency room to the adult emergency room. So sometimes taking that extra minute or two to actually find out what's going on would help. Of course, there are so many easy dispositions in the ED that when the parent tells a story, oh no, this is not serious. He vomited yesterday, he had 2 episodes of diarrhea, he's sitting on the bed, drinking fluids, playing with his cell phone, this kid can go. So those fast ones go. But when it's vague, he's crying in pain, he's in he doesn't look comfortable. Those kind of cases are ones where you want to take 1-2 more minutes to say, this kid doesn't look comfortable. And you didn't tell me of abdominal pain, you mentioned his vomiting. Tell me what's going on. Tell me how it started. And the parent might volunteer more information.
Mm-hmm. That's great points. Awesome. Well,
thank you.
Thank you for your time. See you in the ED.
Thank you, Ryan. You have a good day.